Well, the APHINITY study is positive, and it shows an improvement in disease-free survival, which is its primary endpoint, with the addition of pertuzumab to standard chemotherapy and trastuzumab treatment. But also during the maintenance phase, the pertuzumab is added to complete the year of therapy. This is a big game changer, because what's interesting about pertuzumab is in the metastatic setting, in the Cleopatra study, it actually improved survival when it was added to trastuzumab treatment. And it's one of the few drugs that has had that kind of impact on survival. Even in the HER2 space, if you look at kinase inhibitors, or if you look at other drugs in ER positive, like the CDK inhibitors, everolimus, or chemotherapy in triple negative, none of them really improve survival significantly, maybe a month or two. So clearly this is going to be something that is adopted widely, especially in patients that have higher risk cancers, stage 2 or higher, or node positive. And I think that there may be a reason for this. I think that antibody therapy is intrinsically, has components of immunotherapy. And so, because you can fix antibody-dependent cellular cytotoxicity with both trastuzumab and pertuzumab, and so there may be a biological reason why it's having that impact. And the other thing is that the safety signal is pretty favorable. There is some more diarrhea with pertuzumab, but certainly during the maintenance phase that is minimal. And so I think the adoption will be quick and pretty widespread, especially since many oncologists have some familiarity in the early stage setting, having used it in the neoadjuvant setting just during the chemotherapy phase. So it won't be too much of an extension to use it. It will add cost, and that's an issue we always have to look at, and that brings up the aspect of whether there are predictive biomarkers that will tell us who in particular benefits more from pertuzumab. There's some data that suggests that PI3 kinase mutations might identify such a group, that the wild type may do better. But again, this is still very preliminary. So I think for now, it will impact on practice, and most patients with stage 2 or higher that have HER2 positive cancers will get that drug. It's a welcome addition to our armamentarium, obviously. Anything that pushes out disease-free survival, most likely it will at some point show a survival benefit as well.